We're very happy to be here today. We decided that, first of all, I'm Scott Austin. I'm the president of the Benefit and Life Group for Johnson Insurance. We're all going to just introduce ourselves, so we'll do that as we speak this morning. So again, I thought it was a very informative, great session we just witnessed in the other room, and hopefully we can do as good a job in this session. You know, I'm one of those old people that was referenced. I've been doing in this business for over 30 years, and I would say this is the biggest change I've experienced in my time in this industry. And I think others would agree. So I think there's a lot of confusion and the need for a lot of strategy around how, as employers, you face the PPACA, ACA, or Obamacare. Today, what we thought to make this most productive is our goal, to make it productive for you, the customer, just like we talked about in the other room. While Rebecca Smith and I are going to talk about some compliance issues, our primary focus and what we thought would be most impactful is to talk about some strategy. And we hope you guys will agree with that. I really think what's going to make this most impactful is during we'll focus on our presentations, some compliance strategy, but the Q&A is really where we feel we can have the greatest impact and be most informative. And the key there is for everyone to participate. I jot down questions as we go through our pieces of the presentation. We're going to try to keep each one to 5 to 7 minutes as best we can. So if we trigger something that raises a question in your mind, jot it down. We'll get to it at the Q&A. The other thing I want to say is, as much as I don't think any of us up here would like to call ourselves experts. I mean, if you think about how complex this law is, that to me would be quite the comment or boast to make. I'd like to say we're all consider ourselves thought leaders, and I can guarantee you there may be topics that people in the audience are going to have just as much or more information than we do. So don't hesitate if you're in the audience and you're very knowledgeable about a certain area or have questions obviously about it to go ahead and jump in on that. I think we're all going to be available for at least some time after this, so if there's questions we don't get to or they're ones of a more personal nature that you wanted to just ask, as much as we encourage the dialogue, we'll stick around and try to ask those. So the way our agenda is going to go today is Rebecca Smith is going to start off with compliance issues. I'm going to hit on some of the areas that I would say seem to be causing the most confusion with employers. And again, these are just the tip of the iceberg of what's out there, but some that I think might be more impactful. Jeff is going to talk about the pay or play penalties, the mandate, exchanges or marketplace, and then some of the pricing impacts of that. And then Tracy is going to hit on kind of some specific strategies surrounding healthcare reform. Then we'll go into the Q&A session and go from there. So with that, I'm going to turn it over to Rebecca Smith.
All right, and who has the clicker?
And I will
turn over the clicker.
It's going to click.
There
All
we
right, great. Can everyone hear me okay? I'm not even sure if I need a mic. My kids would say I don't, but we'll use one so we make sure everyone can hear me. I'm going to cover some of the compliance areas. My name is Rebecca Smith. I'm manager with Schenck. I've been practicing in public accounting for about 14 years now. Don't think it really seems that long, but it has been. And mainly in the tax area. Actually, the healthcare reform area has a lot of different tax implications within it. My friends and family often say healthcare reform and taxes, I don't really understand how that works together, but there's a lot of things that are mirrored in there. So I'm just going to go through some of the basic compliance items, and then Scott's going to go into some of the issues, and I'm sure I'll jump in at some point with him as well as to some of the things I'm seeing as well. So we'll get started with just some of the benefits, and what I really want to focus on in the compliance area is the things that are probably most significant to people right now, more in the short term. There's a lot of different changes in healthcare reform, some of them more significant and impactful than others. So I really want to make you aware of what the ones are that you should be thinking about right now. So a couple items on the slide I just want to mention, the 60-day notice of plan changes. This went into effect at September 23rd of 2012. And just if you have a plan change, you are obligated to make sure people are aware of that no later than 60 days prior to that plan change. So just little compliance there, make sure that everyone is notified of any material change in the plan. The other thing I want to mention is the pre-existing condition exclusion. This starts for plan years ending after 12/31 of 13. And basically, there can be no pre-existing conditions for anyone. So I guess it's one of the benefits I think many people are seeing in healthcare reform, that you don't have to worry about if you've had a significant illness in the past and how that's going to impact your insurance and if you can get it or not. So I think this is probably, everyone talks, is this a good or a bad thing? This probably, I think this pre-existing condition is probably a good thing that's coming out of it. There was a lot of discussion in our session this morning regarding the employee notice of exchange. That is required to be out to employees by October 1st. So we've got just a few weeks here. Basically what it does is it notifies employees of the exchanges that they may be may have a subsidy that is available to them. And that if they purchase insurance through the exchange, they could possibly lose some of their benefits through their employer. So really what it is just a way for information to go out to employees about what the information is in your current plan, if you have one, and about the exchanges. There's two notice types, one if you have group health insurance and one if you don't, just be aware of that. They are available on the Department of Labor website, and they do come in English and Spanish. So they are readily available for everyone. One thing to note too on the notice of exchanges, we are recommending for most employers, even if the employers that are required to provide this are the ones that are subject to the Fair Standards Labor Act. And so if you're an employer that's not subject to that act, you technically don't need to provide the notice. We're actually recommending that all employers provide the notice. One, you're just covered if you do, and second, I just think it's morally, ethically the right thing to do, for your employees as an employer, to provide them a notice so that they're informed. The other thing I wanted to cover here, annual limits. Tax years beginning after 12/31 of 13, there's going to be no lifetime or annual dollar limits as on essential health benefits. So just to know that's now going to be gone. And then for group health plans and group health insurance coverage, there can be no waiting periods in excess of 90 days. And that is scheduled to start for plan years beginning after January 1st of 2014. There was a lot of discussion earlier too about possibly having, if you've got renewals that are coming in January 1st of 2014, there are some benefits to having some renewals done early, so that some of this stuff, you've got a little bit more time. It gives you an extra 12 months, I like to say, to deal with some of these compliance issues that are starting to come into effect on January 1st of 2014.
Say, just to clarify, you're talking about a probationary period, aren't you?
Correct.
And it can't be like the old-fashioned first of the month following 90 days.
Right.
It's got to be 91st day.
Right, exactly. Yep, so people that have plans where it's got that, first of the month following the 90 days, that's going to be an issue. People have those types of plans, need to relook at those plans and look at how they're going to be able to make sure now that they can not have a waiting period that exceeds that 90 days. Here are some additional benefits. I'm not going to go through any of these on this slide. We can talk about them definitely if people have questions. So if you have anything in this area, we can talk about that in the Q&A. So the flip side is the fees and the other reporting. What are some things that you need to be aware of? Form W-2 reporting's been out there for a while. It's actually been out there since 2010, 11, somewhere right in there. And this is for anyone that issues more than 250 W-2s. So a lot of large employers are impacted by this. Some people have already had to comply with this requirement. So for 2013, to determine if you have to do any reporting, you would look back to 2014 to say, have I issued more than 250 W-2s? I'm sorry, 2012, I went the wrong way. You'd look back to 2012 and say, have I issued more than 250 W-2s in 2012? If your answer to that is yes, for 2013, when you do your W-2 reporting, you're also required to report on there the aggregated costs of employer-sponsored health coverage. And that's going to be the employer as well as the employee share of that coverage. Now, a lot of questions that we get, it comes up frequently, well, is that taxable? What does it mean? It's just informational. It's reported on the W-2. It just provides information. It's not taxable. There's no reporting on any forms that are required. The other item I wanted to touch on is the 0.9% additional Medicare tax. And I want to touch on what's important for employers with respect to this tax. Because this tax applies to individuals who, if you are married filing joint, your AGI is over 250,000, and if you're single or head of household, greater than 200,000. So it does apply to individuals. However, there's some employer responsibility with respect to this tax. How it works is when an individual goes to file their tax return, if they're over those thresholds, they will pay this additional 0.9% Medicare tax. As an employer, your obligation as an employer is if you have an employee who makes greater than $200,000 a year, as soon as they hit $200,000 of W-2 wages, you are required to begin withholding the additional 0.9% Medicare tax. This is only on the employee portion. This is not applicable to the employer portion. And the interesting thing is, as an employer, once you start withholding the additional tax, once they've hit the 200,000, you have no obligation to notify the employee that you're doing this. Now, some employers I've talked to have said, we're notifying them just to be nice and courteous, that you make over this much, we'll be withholding this additional amount when you hit it. But you have no obligation as an employer to notify your employee you've started withholding this additional tax. Some areas that have come up in this area is, well, what if you withhold and then they go file their tax return because they're joint and their spouse doesn't work? That question's come up a lot. I have a high wage earner, I'm going to start withholding this tax, and maybe they make $225 and their spouse doesn't work and they go file their tax return, it's married filing joint, and the tax doesn't apply to them. What happens? They get that refunded when they file their tax return. You can also have the flip side, where maybe someone is making under $200,000 and both spouses work. They go file their tax return and the tax applies. They'll then pay that tax when they file their tax return. So just wanted to make you guys aware of some of the employer responsibilities when it comes to the 0.9% Medicare tax. We're also going to talk the employer mandate. There was a lot of discussion this morning. Should you pay or play? We're going to get into that in a little bit more detail, so I'm not going to cover that at this point because Jeff's going to talk a little bit more about it, and we're going to have some additional discussion around it. So with that, we are going to go right into the areas of confusion with compliance.
Okay. I got
Because there are many.
I think I drew the short straw on this one. And again, because we're trying to keep our discussions to 5 to 7 minutes, I am going to hit on these very briefly because probably each of these areas you could take an hour on. Mm-hmm. So I guess what I would leave you with is get good guidance in these areas, if anything. If you're not sure, these are things you need to talk to your agent, broker, attorney to get clarification on. So the first one is on the out-of-pocket maximums. As most of you are aware, with the ACA, large groups that aren't grandfathered have an out-of-pocket maximum of $6,350 per employee and $12,700 per family. But there's special transition relief, and I'm going to, unfortunately, because if I just sat up here, and those that know me know I could probably ramble on a little bit, I'm going to try to follow a script so I can keep it condensed. So I apologize for not just being more conversational. Otherwise, I'll go exceed my time. But anyway, if there's special transition relief that if you are, and this really applies to self-funded plans, but if you have a separate TPA managing your major med and a PBM, for 1 year, for plan years that begin on or after January 1 of 2014, If those, let's say today you have a out-of-pocket maximums that when you combine the two exceed those limits, you can continue to exceed those limits for this 1 year, starting if your plan year begins on or after January 1, 2014. There's kind of a 1 year transition relief, but there are some restrictions there. One is the major medical plan does have to be in compliance. So you have to have your major medical plan underneath those 6350 and 12.7. But let's say you don't have caps or whatever on your PBM. For 1 year, you can exceed the two combining going over that. After that, you've got to get it into compliance. Again, this really applies to self-funding because I think it would be rare to find a fully insured plan that would allow you to carve out the pharmacy piece. So that's one thing, and again, we can come back if there's more questions on that. The other on the HRAs, here I'm referring to health reimbursement accounts. I think there's been a fair amount of confusion in this area as well. I would say probably in three primary areas. One is the ACA has prohibition on the annual limits, which Rebecca just referenced, so where HRAs come in with that. The fees that she also referenced, HRAs have caused some confusion about that in that area as well. And then also the impact on the affordability requirements that were discussed in the earlier session, that 9.5%. So on the annual limits, HRAs are considered health plans, and they don't have annual limits. So by definition, you could say an HRA is out of compliance and can't be allowed, and that was, I think, the initial view when the law came out. But knowing the number of employers that use HRAs, I think they use good judgment on that, and there's been recent guidance that basically says you can use an HRA within your health plan and be compliant as long as it's an integrated HRA, and there's a lot of definitions around that. I would say the main thing to take away is it has to be, the HRA can only be available to your employees that sign up for the group major medical plan. So that's the requirement for being integrated. It has to be offered alongside your group major medical plan, and can't be standalone, or there's some other HRA definitions. So, and again, the group major medical plan does have to comply with the annual limit regs. So that piece has to be in place, but the HRA can be added on top of that as long as it's integrated. On the fees, here I'm talking about the PCORI or research fees and the insurance fees. The issue here is an HRA is a separate plan, so do I have to pay my fees for both my major med plan and my HRA? And the answer could be yes. If you are offering a self-funded major medical plan, you do not have to also pay for your, count your HRAs as a separate, for the fee, the $1 going to $2 on the PCORI fee. If you have they have the same plan year and same plan sponsor. So if you're the sponsor for both and they have the same effective date plan year and it's a self-funded major medical plan with the HRA, you don't have to pay again for the HRA. So you're paying one time for the major medical plan. If you're fully insured and you offer an HRA, then those aren't viewed as same plans. Those are different plans, and you do have to pay, on top of what you're paying for your major medical plan, the fees for the HRA. The only caveat there is for the HRA, where with the major medical plan, it's for covered lives, so employees and dependents. In this scenario, if you're fully insured offering the HRA, you only have to pay for the employees on that HRA in addition to the major medical plan.
I was going to say, on the HRAs with respect to that fee, there is a ton of confusion as far as, well, this is the type of plan I have. Am I subject to this fee? I got a lot of phone calls 2 weeks before July 31st this year saying, well, this is the type of thing I have. We call it an HRA, but I don't know if it's really an HRA. There's very specific definitions in the regulations as far as what HRAs, I will say loosely, are applicable to that fee. So it's really a lot of facts and circumstances and getting down to understanding the plan and determining, is it truly an HRA or is it something else?
Absolutely. Another issue I tried to emphasize group, the employer sponsored. Some employers may have, they decide to go a defined contribution route, offer individual plans to employees or, employer paid for individual plans. That does not allow those HRAs to be, considered integrated and that type of thing. On the reinsurance fees, this is the $63 fee, there's no additional fees for the HRA as long as they're integrated. I talked about the definition of that integrated. Has to have the same effective date and same plan sponsor as the major medical plan. So you don't have to pay twice if it's an integrated HRA over and above your major medical plan. The last thing on affordability, just to note, and this gets back to that 9.5%, that any amounts as an employer you're putting into an HRA for your employees can be taken into account when determining affordability. So let's say, for example, that the cost to that employee exceeds 9.5% without the HRA, but if you're throwing $1,000 into the HRA, and that can bring them back down below the 9.5%. So it can go towards meeting that affordability requirement. Next, real quick on controlled groups, and there was a little bit of discussion in the earlier session, so I'll try to be brief on this. Obviously, the Internal Revenue Code has some definitions and rules around controlled groups. I just came up with some ideas of examples where that could lead itself and become confusing. One is if you're trying to determine if you're small group or large group, and let's say today you have a group of 40 employees, which unfortunately probably doesn't impact this group, but you got another 40 out in California. They've been operating on their own, same ownership, so a controlled group, separate plan. Those have to be combined when you're counting number of employees. Are you small? Are you a large group? As well as meeting other requirements within the law. Exchange notices. We're talking about that. A lot of people don't realize that. Well, I've got this collectively bargained group over here, the union. Am I responsible for those notices for them? Yes, you are as the employer. So you have to make sure that the employees, including union employees, are getting those notices. And then the final thing, and Jeff can feel free to jump in on this one, getting back to that definition. You could meet the definition of a large employer. And let's say if you are a large employer, you have the ability to have more than a $2,000 deductible. Small employers, that's their limit. Large employers can go above that. You have your out-of-pocket max cap. But you could have, let's say, a $3,000 deductible. But if you've got a situation where your 40 employees, here, and the 40 employees in California make you a large group by definition, you can have the 3,000. Odds are, whether it's WPS, Humana, or whatever else, if that's your carrier here for the 40, you're going to get their small group chassis products, and you probably will not be able to get a $3,000 deductible. Is that fair?
Not without some doing.
Okay.
The off-shelf product is
good sales guy.
$3,000 deductible. If you really want our product, I'll find a way to get you the $3,000 deductible.
I teed that up for you, Jeff. So the last one I would say on the determining full-time employees, I personally think this is probably the biggest area that you need to be concerned about and on top of. And again, we're not going to have time to talk about all the ins and outs of this now. They did talk about it in the earlier session. To me, it's got the biggest potential financial impact to you as an employer, and also is very complex. And what we're talking about here is how you count and report employees for full-time status as far as determining coverage and when that coverage date begins, kind of the look-back periods that we talked about earlier. And to me, the potential financial impact is if you don't calculate this correctly, and let's say you have every intention of meeting the requirements that say you have to offer coverage to 95% of your employees, and let's say you hit 94% because you didn't count somebody right, you not only are paying for the coverage that's expensive to begin with, you are also paying the $2,000 per employee penalty of not offering coverage to 95% of your employees. So to me, it's big that you get this one right. And again, if you're 51 employees, that impact is obviously less than if you're 500 employees. So it's very important that you calculate your employees correctly, especially if you've got a lot of variable and seasonal employees, because that gets pretty complex. There's all kinds of rules as far as what those measurement periods can be and those types of things that, again, we don't have time to go into today. But it's very important that you understand that. And as it was referenced earlier, if you have a January 1 effective date and you want to have a 90-day administration period to collect all that information and set up your payrolls and all that, you probably should start counting your employees per the guidelines effective 10/1 of 13. Mm-hmm. So even though the employer mandate begins 1/1 of 15, you got to start counting your employees, and potentially you should start counting them October 1st of this year. So with that, I'll transition it to Jeff.
Oh, thanks, Scott. Again, I'm just going to reiterate sort of the intent or our thought about how we would conduct this meeting, and that we want to just sort of tee up and throw out a bunch of ideas for you. And that first part was sort of compliance thoughts for you to chew on a little bit. I'm going to take us through some kind of strategic thoughts to tee up and for you to chew on a little bit. And I'm going to, some of the things that we start discussing or that you are thinking about or talking with your consultants are that, all right, now there's healthcare reform. The rules have changed. There's a lot of differences from the regs that I'm used to in the past. So what do I do? I mean, how do I get my hands on that as an organization? How do I make sure that I'm thinking appropriately about delivering benefits in a way that meets my organizational goals? So we're going to talk about, I'm just going to throw out a number of different things. I'm going to hit on sort of one strategic concept and then turn it over to Tracy to hit on another one where we will get down in the weeds. And then hopefully from there, we will have inspired some good questions for you all, and we'll have a spirited question and answers session. But some of the things that you need to be thinking about now, or strategic considerations, are your plan design options. There are requirements now that there weren't before. We talked about that. So do your plans meet the definition of minimum essential health coverage and minimum value, even though there's not a penalty right now? I mean, that's the first thing you need to look at. There's different employment and enrollment options to look at. Do you want to utilize technology more effectively? Do you want to consider linking up to a private exchange to help facilitate that process? If you're not self-funded now, is now the time to think about that. We talked about that a little bit earlier, but that certainly is a discussion we have a lot of our employers talking about. I'm 150 lives, I'm fully insured, I've never had the risk tolerance to be self-funded before. Why now? Should I consider it now? And those are definite strategies to be considering. Network options, Tracy's going to talk about that a little bit, but that is different. If you've noticed when you look at the carriers that are on the exchange in southeastern Wisconsin, I think without exception, they all offer narrower networks. That is the way this is going to evolve. There's benefits for everyone involved to be able to effectively sort of harness a relationship with providers in a new way, and those are things that you might want to consider. And then I'm going to talk a little bit about pay or play. Mike mentioned in the earlier session that there's a new vocabulary, and it's interesting to me that this pay or play discussion, it's almost second nature to all of us now. And what does that mean? Do I offer insurance to my employees or not? And that's a decision that you or someone in your organization may have made generations ago. That yes, we offer employee benefits to our employees. We're somewhat paternalistic. My competitors do that. It makes sense. But the reason pay or play is a discussion worth having these days is because the rules have changed. They're considerably different. But I think for the most part, especially larger employers that we work with, you offer benefits to your employees for a reason today. That probably doesn't necessarily change. The question is, how do you use the new rules to evaluate what is the right way to provide an opportunity for your employees to get health insurance? And one of the discussions we talked about earlier this morning, and one of the kind of unique things about this is that, for instance, you might be a company that has some lower wage earners and you're not contributing a whole lot to the insurance. Maybe you're paying 50% of the single plan. You, in some instances, may be doing a disservice to your employees if they've got a family of 5. You're contributing 50% of the single plan. It's deemed affordable to the employee. It meets minimum value, so they are not eligible for a subsidy on the exchange. It might be a lot better deal for them to go to the exchange and take the opportunity to get a rich subsidy. So you're attempting to provide a great benefit to your employees. You're finding a way to afford to contribute 50% of that premium, and it might not necessarily be the best deal for your employees. And that's why this whole pay or play discussion is a valid one, to really step back and take a look at the strategic reasons you offer benefits, how you offer benefits, and the new sort of gamut of options that are out there. And I do believe it's time to kind of press Control-Alt-Delete or wipe the slate clean and think organizationally, look in the mirror and say, why do we do this? How difficult is it for us to retain and attract the quality employees? A lot of discussions are going on. If you look at pay or play as a simple financial discussion, which is sort of where you start with that, the answer is always to pay. It's very rare that you're paying less than $2,000 per each of your employees for your health insurance. So if it's purely financial, pay the penalty. But you don't have to pay for insurance for your employees today. There's a reason you do that. And I just wanted to throw that out there. That's the whole concept of pay or play. And some of the other dynamics that are changing that make this discussion a valid one is that, for many groups, small groups in particular, the costs are going to go up substantially. That's where I see sort of decision as to whether or not employers are going to offer benefits, in particular in the small group space, they might be getting pounded. And they might realize it's just not worth it anymore. That price tag, I was near a tipping point already. My price may have gone up 55% with the new rules, and it's no longer worth it for me to do that. Maybe I'll gross up my employees' salary and let them go buy something on their own. So the new dynamic of the cost structure of health insurance is creating a situation where employers are looking at what they should do. Again, if you stop offering benefits, we call it a soft landing, but the reality is it's guarantee issue. That doesn't exist today. Well, we have HRSP. In the new environment, if you do not offer insurance to your employees, they can buy insurance. No one can be turned away, and there are many opportunities for them to do that. 4 of them are on the exchange here in southeastern Wisconsin, where they are potentially eligible for a subsidy, and many other off-exchange solutions. So whereas today, we work with many companies, they offer insurance because they have a couple of key employees that they know have some medical challenges, and they don't want to leave them out in the cold. They're like, I can't do that. One of my key employees has a kid with MS, and I need to take care of them and offer them benefits. They have an option now. They have multiple options now, I guess, where they have HRSP today, and in the future they'll have multiple options. So that is a dynamic that changes a little bit with the guarantee issue. And I mentioned a little bit about how some employees might actually you might be doing them a disservice financially by offering benefits, and those are the things that need to be considered.
Top one.
So, as you address the whole pay or play discussion, you're looking at what's the skill level of the employees that you need, how available are those skills in the marketplace. I still believe that the lion's share of larger employers need to offer a competitive benefits package to attract and retain the employees that they need. Mm-hmm. And if that's really important to you and it's valued by your employees, I'm not sure you're going to want to do something different, especially right out of the gate. I think we should all be cautious about making really quick decisions as we get into the first year of healthcare reform. Again, how competitive is your compensation plan? What is your peer group doing? These are a couple of charts that actually sort of take you through the pay or play decision-making process, a flow chart. And, the first step of that is counting your employees, as Scott mentioned, the new way of counting your employees. And literally there's seminars that are 4-hour seminars on how you count your employees appropriately. But you have to know how many employees you have, and you have to do the value equation or do the equation of determining whether or not you're offering minimum value and affordability. And again, the penalties do not apply in 2014, but you should start thinking about it because they will apply in 2015. You are expected to make a good faith effort in meeting those regs either way. So this just sort of takes you through a thought process of doing that, and that's another one. But one of the things I wanted to talk about is assuming, just to give everybody a better understanding, because this is what's imminent. October 1st, the exchanges are up and running. And where I find there's probably not a great depth of understanding because it's really confusing is how those things work. So we're going to talk later on about more of the play strategies. You're going to continue to offer benefits. How do you implement strategies to get a handle on your healthcare costs? Let's say you choose to pay. You're not going to continue to offer employer-based benefits to your employees. What are their options out there? What's new, what's different? Well, the reality is, we talked about there's no underwriting, there's no pre-acts, there's no ability to rate based on risk. It's guarantee issue. Your employees or anyone that doesn't have an employer-based health insurance plan will have many options out there. I don't know how affordable they're going to be because there's new richness to the benefits. There's the essential health benefits that are beefed up. There's, out-of-pocket maxes are limited. The modified community rating, we talked about it this morning. That is a driver of price that will go up. If the OCI's averages were in the 50 to 124% range that they indicated. So the result is higher rates, especially for the young and healthier. And a point that Mike alluded to in the earlier session, and this is what's new and somewhat uncomfortable to me in the, on the carrier side, and I'm sure for you on the broker side, where we are used to consulting to customers about sort of what's right for them from a benefit perspective, what deductible level, what features are important to you. Income is such a huge part of this equation now. You can't really talk about or think about finding the right solution for a consumer one way or another without taking their income into part of that. If you go to the exchange and fill out the eligibility portion, the first part that you fill out that determines whether or not you're eligible is a bunch of personal information, including your income levels. It's absolutely part and parcel to determining the right solution in the future. So that's new and something I think will take everyone a little bit to get used to. So, with respect to how the exchanges work, here's just a couple of graphics that show it, or how the subsidies work. Many times we think of a subsidy as an amount given to us by the federal government to subsidize the price of something. This kind of backs itself into that. So the amount that people that are eligible for a subsidy will pay for the health insurance is determined based on their income. It's really irrespective of the price of the health insurance. It doesn't matter what we, the carrier, or any other carriers charge for it. It's based on your income. So this shows the federal poverty level. 100% of these are 2013 numbers, I believe, but 100%. So if you're at the FPL level for one person, it's 11,490. If you're at 400%, it's 45,960. And then that second column shows, based on the ACA, the percentage of your income that you can pay no more for a health plan on the exchange. So let's say you are at the 133% of the federal poverty level. You are a single person, you're just out of college maybe, and you've got an entry-level job, you're making $15,000 a year. The most you can pay for the second lowest cost silver plan on the exchange is $305 a year. Doesn't matter what the premium of that is, that's what you would pay. It's 2% of your income level. If you were at 200% of the federal poverty level, you're earning $22,980. The most that you would be able to have to pay for insurance for a silver plan, and the way it calculates is the second lowest cost silver plan on the marketplace, is $1,447. So that's sort of the income relationship to how the subsidies work. And I've got another slide that shows how it works for a family of four. So these are the federal poverty levels and those same percentages. At 200% of the federal poverty level, you're earning $47,000 if you've got a family of four. You cannot, or you will not have to pay any more than $2,967 for the second lowest cost silver plan out there, and you see what it is for the 133% of the poverty level. Now, when you get up to 400% of the federal poverty level, that amount, that almost $9,000, is probably in the neighborhood or maybe more than what some of those insurance premiums are for. So the subsidy is worth a lot less at those higher income levels. But down between the 250% and lower, it's substantial. That insurance for that family of four is going to cost substantially more than that $4,700. So your subsidy will be pretty hefty. But that's something that we just wanted to throw out there again to inspire a conversation, to give everybody a better feel for it. We hear about the subsidies and the exchanges. This is how it works. This is the math behind it. And that's what people will end up having the opportunity to pay for the selection of plans that exist on the exchange.
I think this subsidy is really, really key when it comes down to, do I pay or play? Mm-hmm. And understanding your employee base, what's the makeup, what employment base do you have, how is that driven? And if you look at it, because this subsidy is based on, this is the same throughout the entire United States. In Wisconsin, this is a huge thing. In New York, probably not. Because I would beg to bet, family of four in New York, easily 94,000, not a problem. They're not probably as concerned about this. In Wisconsin, we have a very large percentage of our population, I've heard numbers all the way probably 75, 80, 85%, that are gonna fall into this. And if I'm an employer that's operating in multiple states and I'm looking at my employee base, I'm gonna need to kind of get a handle on, well, maybe I'm operating in Wisconsin and California. Maybe this isn't as big a play factor, and so, for my California employees, and how I look at things for them are going to be different than how I look at things for my employees in Wisconsin.
Mm-hmm. I'd say the other thing is that you're, in some cases, apples and oranges, because if your employer's providing, it could be on a pre-tax basis. Mm-hmm. These are all after-tax. Right. So you want to make that adjustment when you're looking at this as well.
Mm-hmm.
Yeah, that is a really good point. And I think the overall point to all of this is that, and if there's another takeaway I could, recommend to everyone, it's that, and you obviously all know this, you're engaged, you're here today, there is a lot to know, and this is a significantly different situation than it was the rest of your career. So the key is to really be knowledgeable about it, learn as much as you can, and use, have a good broker, a good CPA, and a good attorney to help you through some of this, because it is significantly different. And I think it also is the opportunity. I think many times, you know, your insurance agent walks in with your renewal, you negotiate it down, you pay for benefits, your deductibles go up, your premium goes up a little bit, your contribution level goes up a little bit. We're sort of in this cycle that just sort of self-perpetuates itself. That's what you've been doing for years. Renewal comes in, you negotiate it, maybe you shop the market, deductibles go up, premium goes up, contribution goes up. That's what we've all been doing for years. And I think now is the time to just sort of stop and say, all right, let's take a little bit higher level perspective look at this and determine what's the whole idea of what we're doing and what's the best way to deliver a valuable solution to my employees that's benefiting them the most. And Tracy's going to talk about another opportunity to do that, another strategy that you ought to consider.
Thank you.
And you know, from there.
I mean, that, picking up on what Jeff just said, I think this is really important. You know, thinking about how you can provide the maximum benefit to your employees at the best cost is kind of my segment of this conversation. Very quickly, I'm Tracy Klein. I'm co-chair of the healthcare department at Reinhardt. I am not in the world that all these folks are in. I'm a healthcare lawyer. I've spent probably 30 years representing health systems, provider groups, PHOs, provider-based health insurance companies, and really I'm on kind of the different side of the world from these folks. But I think that maybe what's interesting, and I kept saying to them, geez, would you like our benefit attorney to come and do this portion of the presentation? And the answer was no. And I think it was the right answer, because really the combination of what we understand as healthcare lawyers, where the healthcare industry is, and also what the requirements are on employers really is the missing link here. And as we've all talked about, this is a 2,000-page act. No one knows everything. I talk about premium subsidies. They're advanceable and refundable. They're tax credits, but they're advanceable, refundable. And I saw something yesterday that I can't even tell you if it's true, but the Q&A was basically, can I take the tax credits and pay the premiums as I go along? Think about that. Premiums would not then get paid. The answer to the question was, well, you have to have enough to pay the premiums along the way. So it's a lot of complexity here. But so I'm going to try to get out one idea for you all to consider that I think is an important idea, and it's the idea of narrow networks. You've got information on our healthcare department in your handouts. There's a second page with resource center, resource information, and in that little handout, I know this is a hot question, but apparently the DOL notice, there was a issuance of a regulation that said basically there's not going to be a penalty for failure to provide it. And so we have that problem with a lot of our Taft-Hartley plans. They're really concerned that the notice will be so confusing that it'll create all sorts of employee relations issues. So you may want to check with your counsel, because you might, I'm not saying ignore the law. What we're seeing with this law is there's all these requirements, and now we're saying, well, we're not enforcing, we're not going to do anything. I guess you have to make a decision from a compliance standpoint what you're going to do and what you're not going to do.
Yeah, and to add on to that, we've seen it actually where some employers, we've worked with them from the standpoint of they've done cover letters unattached to the notices, which provide some more kind of the position of where they're at and what they're looking at, or what they've had conversations, sharing information. So just more transparency through a cover letter, because that has been some of their concerns as well. Is you look at this and it's not very friendly if I'm the employee and I'm reading this, and then they're getting it and they're like, well, what does this mean to me? That's the other thing. You know, the average person doesn't understand what this is going to mean to them. And so they're trying to, as an employer, provide some additional clarity and provide resources, and they're doing it through a cover letter that's attached with it. So it gives it a little bit more insight and more specific as to what direction the company's coming from. And we've had a few employers that have done that. That
we
they
just
feel
got
is
ours
helpful.
at Johnson yesterday, and it was an email where they explained, you know, here's this attachment or whatever with some, you know, explanation. The other thing, and again, I'm not recommending this, I think this would be one you want to talk to counsel on, is that model notice. You don't have to send out all aspects of that. There are pieces that are required. There are also pieces in there that you could take out. Right. But I would say before you do that, you know, talk to your legal counsel on that.
But I think you said it in your question. The answer is, I think it does require some PR and have it to be part of a communication strategy, because that model notice on its own is going to confuse your employees. You're not going to really get.
I think it's going to anger them.
Yeah, it's a government document as a model notice, and it's not that user-friendly. And I think, you know, I would strongly encourage you to consider having that be part of a communication strategy as to the direction that you're going, and that's a requirement to send that out. But I think it does require a little PR work.
I think kind of related, and Jeff knows more about a lot of the exchange issues, but I think one of the questions in the exchange is does your employer provide affordable coverage and it's actually less, it's not affordable. It's some, good coverage or, pretty kind of wide open question to your employees to, say yes or no to that. So I mean, some of the wording of this is leaves a lot to be desired. Yeah, Tom.
I've got a question. I recognize that the $3,000 penalty will be postponed to 2015. But let me ask you this question. Here's an employer, an example. An employer where this year 50 people go into the exchange this year because they had Badger here as an example, but they went into the exchange. So now, come the renewal of 2015, they're still in the exchange. Will that penalty now be brought back to that employer for 2015? Let's say he's got 50 people minus the 30 that are in that exchange for 2015. They moved there 2014, but they're still there.
As it stands today, that's what they're saying, that the penalty does not apply this year, it does in 2015. I think a question would be, if they're on the exchange, that means they're eligible for the exchange, meaning their plan's either not affordable or doesn't meet minimum value. If it does those two things, they wouldn't be eligible for the exchange. But assuming they are, unless they change something else, the answer to that is yes, there would
Well,
be.
there's a lot of employers up in the northern part of Wisconsin that have, you mentioned it earlier in your meeting, your Badger Care as an example. And you're going to be moving those Badger Care people into the exchange. So they're going to be in the exchange. So I guess that employer's going to get pretty big penalty.
Well, I mean, the key is whether the employer is providing affordable coverage.
Right.
They can go in the exchange, but if the employer is offering affordable coverage that hits
They're
that,
not.
then they're subject to
Then they're
the
subject
Right, then they're subject to it.
$3,000 penalty to the maximum,
I mean, I think the key there is managing the affordability. If for some reason, somehow, those employers could manage the affordability and be offering affordable coverage, those employees can still be in the exchange. That's fine. But that employer is not going to be subject to the penalty because they've offered affordable coverage.
And again, there's some employers that can look at this and kind of look how they're going to leverage the exchange and look at the population that might go in there, because this can go either way. If typically your lowest paid are your youngest, and they go, what's that leaving in the rest of your group? And so how is that going to adversely impact that? On the other hand, you could set it up, and again, the thought was with, let's say, your wellness, the fact that you can differentiate 30%. Well, if that makes it unaffordable for the people that aren't in wellness and the people that aren't engaged in being healthy going to the exchange, that may not be a bad thing, because that could improve your population characteristics of your group. So I think, as you work with your, consultants and that's what you want to be thinking about. How do you take all this change, to Jeff's point, and try to work it to your advantage the best way you can? Again, beyond the fact of doing what's right by your employees and for your business, whether you even offer insurance, those types of things. I think a question back here.
Oh, thank you. We've been to every seminar and read every piece of literature. And I still have the same question. We are only obligated as employers to offer insurance to 95% of our employees. How do we determine the 5% we don't offer to?
Well, again, I'll start, and absolutely, I'm not the end-all with this question. It's very complex. I mean, there are certain requirements on how you calculate your employees, and Jeff made the comment, you can go through that. So let's say you miss a few, you miscalculate or whatever, then, as long as you're offering to the 95%, you're fine. If you miss too many, you're going to be subject to the penalty. So that may not be the question. Are you saying maybe you
How do you pick
purposely
and
carve out
choose?
5%?
Yeah.
Yeah, I've heard of that
Yep.
strategy. You can purposely, and I've got 100 people. I've got 100 full-time. You've done your count. It's 100. You have to provide it to 95 people.
You could get into some
people have
discrimination
said
issues,
that
too.
think
you
that-
got to watch that though, because you can then get into some of the discrimination areas. And how do you carve out who you offer to and who you don't? I mean, is there a group that you can carve out that makes up 5%? Maybe.
It's best not to do that.
Yeah, I mean,
Yeah, it's tricky ground.
it's tricky. It's tricky ground because exactly.
It's not provided, it's an offer.
That's right.
Right.
You have to offer it to them.
Yes.
Right.
Yep, exactly.
Yeah.
Yes.
I guess my question is, as
whatever, a business owner, when I go to the exchange I don't offer insurance now, but I'm over the limit on employees. The way I understand it is that if I purchase a plan, they have to offer me a plan. I mean, I have to get an insurance agent in my office that's gonna sell me a plan, correct?
Well, you may not get an insurance agent in your office, but you will be able to get a plan for you, and you're talking about in your employees?
Because none of my employees will take that plan because I'm a in-home care provider and they're all on either Badger Care or whatever. So no one's gonna take that plan. I'm gonna purchase that plan, no one's gonna take it. So I cover all my bases.
Sure.
But someone has to offer me a plan. In other words, I can't get an insurance agent to write me a plan because none of my
Right.
employees will take it.
Right.
So my question is if I go on the exchange, someone's gotta give me a plan even though no one's gonna take it.
And you're talking about going into the shop, the small group
Yes.
exchange?
Well, small, I have to be large because I have 100 employees.
Yeah, well, this year, the exchange is only available to small employers, so that's under 50.
This year, 2014?
Yeah, yes, and 2015, I believe, 2016, I think it goes to 100.
That's right.
So, but this year, as an employer, you don't necessarily, and you correct me if I'm wrong, Jeff, you're on the carrier side.
Right,
correct.
but the fines kick in.
Fines kick in 2015.
Yeah, but they do look back on 14, well, regardless.
Well, 14 is how you're gonna measure your full-time, just determine who gets it. Fines are effective 15 and going forward. So you're not subject to any penalties of not offering coverage in 2014. It's 2015 that you would face that.
Right, but I guess it goes back to my question
Mm-hmm.
again. If this is because Massachusetts currently has this insurance plan, we're modeling this after the Massachusetts plan, is that correct?
A lot of components of it are. I mean, you're the exact type of employer that I've had a lot of conversations with, especially while there was a penalty for 2014 that are challenged with this. This control group question where these restaurants or health club memberships, but you are in a challenging situation. You don't offer benefits now. So in 2015, when the penalties kick in, if your employees end up on the exchange and they get a subsidy, and they're eligible for a subsidy, meaning you don't offer a plan that meets minimum value, affordability, and minimum value and affordability, then you would get a penalty of $3,000 for each one of those employees that are on the exchange, up to a maximum of $2,000 per penalty. So you are the type of employer that is going to be mandated to offer insurance or pay a penalty, or you cannot offer it, and you'll have a $2,000.
Fine, and I'll purchase the plan, but no one's gonna take it.
So a contrary or a question maybe, if your workforce, I don't know, maybe it's a matter of understanding your workforce better because maybe if they're all eligible, now you said Badger Care, if they're eligible, they continue to be eligible for Medicaid?
Well, a vast majority.
Because if they're eligible for
Or some form
Medicaid,
of
then they're not, then you don't have the problem. They have to get the premium subsidy, which is different than Medicaid. If they're
Right.
getting Medicaid, you're not gonna get taxed.
Right.
So your analysis is almost to go back and say, look at the household income of your employees, or in some way figure that out. Figure out if they're gonna be eligible for Medicaid or the premium subsidies. If they're eligible for Medicaid, that $3,000 is not gonna apply to you.
Right.
So you could say, well, I only have a quarter of them are able to, are gonna be eligible for the subsidy, and you could do the math.
Well, but it goes back to the question is, if you go on to shop for the plan.
Yeah, you still have to,
they offer me a
yeah.
plan that I can offer to my employees.
Right.
That is affordable. So you're covered either way.
Yeah.
And you're not gonna purchase the plan because they go on and purchase it themselves, because it's more affordable to purchase it themselves. So I will be covered as an employer offering a plan, but that plan has to be, I have to be able to buy that plan.
Yep.
But if you offer that plan to your employees that's affordable and meets minimum value, they are not eligible for a premium tax credit subsidy then. So then they're not eligible for it, so they probably will take that plan, because otherwise they'd have to pay full freight.
I think I can help them out here. I think what the problem stems from is the participation requirements that the insurance companies have.
Yep.
And so the question really should be, what is Arise and what do you know of your competition, what they're doing to address participation? Because there could be gentlemen like him that are trying to buy a plan, but don't meet participation requirements because not enough people take the insurance.
Yep. That is the issue, but I believe the where it is intended to work itself out is that those employees, if they're on Medicaid, it's a different story. They're not eligible. They don't count towards that $3,000 penalty. If they're not, if they're more than 100% of the federal poverty level, they wouldn't be eligible for that subsidy. So they'd be paying the full freight of that insurance premium off the exchange because if you've offered a plan that meets the criteria that it needs to. So you likely would have participation because that would, it'll likely be a better deal for them to take the 50% that you contribute to their plan or whatever you contribute to their plan to make it affordable to them. But those are the really challenging situations that require a lot of analysis.
Yeah, I think, today, obviously, employers have participation requirements, and if you don't hit them, you may not be able to get coverage through an employer. I think what's still unanswered, and maybe Jeff has answers, is what's going to happen to those participation requirements going forward? Because I have heard different things. I've heard some of them are going to say, anybody that's eligible for subsidies on the exchange, you don't count them when you're determining your participation. So you can carve all those people out, and now maybe all of a sudden you meet participation requirements. And I don't know if WPS has a position on that yet?
We don't have it completely dialed in. I mean, the idea when the employer penalties apply, it should self-regulate itself. Because if you're going to offer benefits, you need to offer affordable benefits and minimum value benefits, and if your employees don't participate in it, then you're going to pay a penalty on behalf of them, so we wouldn't worry about it. When there's not a penalty, it is a question that we aren't quite sure how we're going to mandate, because participation is kind of an underwriting rule. If you have 100 employees, we don't want to necessarily get the 5 worst on your plan that really need it and can't get anything else. We'll never get enough premium for that. So that is one of the things that I'm not sure how we're going to handle that, where in an area where there's not a penalty, but I believe we can still apply participation guidelines. So if you don't have a specific amount of employees on your plan that contribute to it, we wouldn't insure the plan.
So
you won't get a cut.
Yeah.
You will not get a plan. You don't need participation requirement. Right? He's got 100 employees. These are actually employees.
well.
Well, and keep in mind, you don't have to offer
I
a
would
plan
say
in
I'm at
2014.
60 full-time
Right.
employees because they count your equivalent. So you're at 60 full-time employees, no one has health insurance now. I have to offer health insurance.
In 2015.
Well,
What's
I
your-
don't have to, or I pay the fine.
Right.
What's your
Right.
local,
$3,000 per employee over 30, which basically comes to $60,000-$90,000 a year. I'll offer a plan if I can purchase a plan for $60,000, $50,000, which you can't.
You can't.
But my understanding is, the way the government's running this is that they have to give me a plan. I have to be able to buy a plan from the government to offer to my employees.
Yeah, well-
we could try to get back to you on an answer to that, but I
Those are-
no.
Get a plan from Verizon. If he gave you a census for his 60 employees, you'll give him a proposal.
Correct.
All right, we got that settled.
Sure. If
Are
you
there-
give the census to Arise, of the 60 people, he will give you a proposal and rate. But you're not gonna be able to afford it.
Right.
So.
All right, any
Are there other questions?
other questions?
Up in front.
Currently, I have a large sales organization that is heavily commission-based, and they have to write minimum requirements every month in order to qualify for our health care. How is that going to change? Is it going to go away? Can I still tie it to their minimum sales numbers? Or
that's a
is that,
unique
can that no longer
Boy.
be attached to that?
I don't know the answer to that question.
So these are considered common law employees, I'm assuming?
Yes.
Okay, that was my first question. And you're tying whether or not they get insurance based on how they
Whether or not
perform?
we pay for their premium or not. So
Okay.
if they do not qualify, they don't write minimum sales numbers, they have to pay 100% of the premium at this point in time. But if they do hit their minimum sales numbers, which are very, very reasonable, then we will cover them. By the way, then we will cover them the same way we do with other non-sales employees.
And you're fully insured?
Yes.
Because, one area that comes into mind is the whole, non-discrimination testing, just like you have on 401K plans. That now for fully insured employers, not now, but in the near future, that's going to be an issue that you got to make sure that you're not favoring the highly compensated, just like you do with 401K. But I don't know, you ladies, that's kind of a new one I haven't heard. That's interesting.
One.
Are they full-time?
Yes.
I guess maybe it's a 95% test then, maybe,
Yeah.
as what you try to
Yeah.
draft around.
Yeah, because if you're gonna look at the penalty itself, you're gonna say, you're saying we already offer insurance, but you'd have to offer it to 95% of your full-time people. If those, I guess that's where you can play around with it a little
Yeah.
bit. If that group of people,
Offer those the cost.
right,
Right.
it's true, you're
Yeah, so
offering it.
you're gonna have
She's still offering it
some
to
unaffordable issues
95%.
potentially.
The affordability.
Right, you're gonna get into affordability then.
If they accept it, then they're on the insurance. Well, they're going to be on insurance anyway, right?
They're on it anyways, it's just how much the premiums they
Right.
pay.
So, that would be an example where you might want to weigh in those that don't perform, and maybe there's other ways to treat those. I've been in sales all my life.
Maybe there's other ways to.
But, the thought about, okay, if the cost now becomes a penalty to you because by not providing any contributions, it's not affordable, those types of things, and, again, back to Jeff's point with the new landscape, you may need to step back and see if that plan that you have now makes sense in the new environment. It's interesting.
What about, for this gentleman here, because I feel his pain, we have 177 employees and only 41 participants on our health plan because the deductibles are high and the premiums are high because of some sick people on our plan. What about defined contributions and using a private exchange? What about that strategy for him and for me?
I think there is going to be a growing trend towards that. And, where today, a lot of employers are basically saying, we gotta cap our costs here. And so we're gonna set what we're gonna pay, as opposed to most employers, every time you get a rate increase, your costs go up, so do your employees. So I think you're gonna see more of that, and there are some tax issues, depending on products that you're using underneath that, as to whether that can be deductible or not. And, we talked about use of HRAs. If you have HRAs and you're gonna go into defined contribution and let them buy individual plans, those HRAs aren't tax deductible, or the plans aren't. So, I think it's a trend. I would say it's Johnson, we're gonna have our own private exchange. We're planning on doing that, and we think more and more employers are basically gonna say, I'm going to be not necessarily a provider of insurance, but a facilitator of coverage for my employees to go get that coverage somewhere. And
Because then they would be in a pool of people. So if we went with Johnson's private exchange, there may be better rates because they would be in a pool of people, of everybody that's in your private exchange.
Right, like an association product or something, yeah.
yeah,
So
the
it might-
potential is there that, because I'm assuming with your participation issues, that maybe what happens, you get that death spiral where only the sick ones are taking the coverage and the costs keep going up. They may be, especially when you throw in subsidies in that, they may be better off going to an exchange, and you use a defined contribution approach to help facilitate that. And I think that is a trend we're gonna see in our industry. Yes.
This might be tricky, but, and a hopeful one. We have moved our renewal date up to December 1st for this year. So if we renew, we go on for 12 months. That moves our next renewal date to December 2014. The employer mandate goes into effect January 2015. Does that buy us another year?
What did you
Is
do?
that one of those yes and no? I think there are certain aspects that are going to be effective calendar year 1/1 of 15, and then there are others that would extend. Like I talked earlier about if you're self-funded and you got your PBM separate from your major medical, it says for plan years that begin on or after 1/1 of 14. So yours is 12/1, so you could extend that out. So that's not a 1/1, but I don't know, I'm sure someone else, again, there are people in this audience that get this stuff as well as we do. That one I should be able to know.
But you're offering health insurance today?
Well, yeah.
So there's a lot less issue there because the mandate applies then in 2015, but you're not subject to a penalty because you're already offering health insurance. So that's what you could potentially buy yourself a year on, and I'm not positive of the answer to that because I don't think there is one yet, an answer to that question that they've provided guidance on. But if you're already offering insurance that meets minimum value and affordability, then it's really not that much of an issue. for a larger employer. It's much more, that concept is much more an issue for smaller employers where they might now have to buy a metal tier plan in their first renewal. So they're buying 11 months of the old way versus a drastically different new way. For larger employers that are already offering benefits, unless your plan is, doesn't meet the definition of minimum value, if you've got a $10,000 out of pocket, then it does matter. Yes?
We're renewing on the 1st, and the first information I'm getting from my insurance company is that the community average is 8%. So we'll have an 8% increase, plus they're going to give us a 3% increase for healthcare reform. But then there was a statement that said it could be between a certain level depending on our utilization review. So can they still look at how much we use the plan in addition to the community?
They can now, your last renewal under the, well, you're a large group. I'm gonna maybe let Scott take this.
January 1 is our renewal date.
Sounds like a specific strategy that a carrier is taking, but yeah, for a large group, you're experience rated and they can.
Yeah, you're gonna get a blend probably. You're gonna have, some of it is gonna be based on what trend is for all of their business and what's going on in the market to drive costs. That's probably the 8%. The fact that they're also saying your own utilization still comes into play, that's the other piece. So on large group, that'll continue to go forward. It's the small group, well, it's forever as we know it. But for small group, yeah, that there would be no more ability to say your experience and health of your population, that goes away, isn't going to be applied in 1114. Other questions? Again, if you have more individualized ones, I know this is kind of gone over, but hopefully this was informative. That we get some information in their handouts, and